Imagine undergoing a highly invasive critical surgery to implant a device that will alleviate your cerebral palsy, helping you walk without tremors and stand up on your own, only to have the device fail soon after implantation. 1 in 3 patients who are fitted with an intrathecal baclofen pump experience catheter failure, which leads to the return of symptoms and even death. Our goal is to develop a novel bioinductive catheter for baclofen treatments that eliminates the issues that plague modern intrathecal catheters. I'm Kieran Tremblay.
I'm Emma Smith.
I'm Priscilla Anand.
And I'm Lana Neidig. Before we begin, here's just a quick little roadmap of our presentation today. We'll overall be addressing the clinical need, a quick literature review, our design criteria, our proposed solution, and our proposed plan for testing our device. Before we discuss our device, let's examine cerebral palsy and how to best manage its symptoms. Cerebral palsy is a group of neurological disorders that impacts an individual's motor skills. Within this group, there are several different subtypes that are categorized by how the disorder manifests and what limbs it impacts more severely. This is the most common childhood disability, and it affects 2 in 1,000 live births internationally. There are several options available for managing and treating cerebral palsy. It is important to note that there is no cure for this condition. For less invasive options, physical therapy and rehabilitation are the lowest risk and least invasive methods for managing cerebral palsy symptoms. Orthotic devices, assistive devices and technologies, and mobility aids help an individual with general movement and communication. Combined, all of these options help in improving a patient's quality of life while also maintaining their independence. Medical and surgical interventions are useful in treating symptoms that show little to no improvement through other lower risk means. And these can include oral and/or injectable medications for pain management, muscle relaxants, antispastic, and treating other comorbidities such as epilepsy. In more extreme cases, surgical intervention may be used. These procedures can include, but are not limited to, muscle lengthening, tendon lengthening, and the implantation of an intrathecal pump for drug delivery purposes.
Let's take a quick look at current systems and some of our novel solutions. Intrathecal pumps consist of 2 main parts, the pump and the catheter. The pump is implanted subcutaneously via surgical procedure. Medications are held in a reservoir in the pump and can be dosed continuously or bolused. This medication is then pumped through the catheter into the intrathecal space. The device is battery powered and can be programmed by a doctor to fit a patient's need for dosages. The pump itself has to be filled once every 3 months via injection and has an average lifespan of about 6 years. Current major devices on the market include the Synchromed 2, the Ascenda, made by Medtronics, and the Prometra by Flowonix 2. So, why intrathecal delivery? Intrathecal delivery is a powerful method for treating neurological disorders as it allows for direct interactions of the drug with the cerebrospinal fluid. When drugs are taken orally, they must bypass the blood-brain barrier, but an intrathecal pump allows for the drug to immediately interact with the central nervous system. As a result, the medication can be taken at lower doses and less frequently. Additionally, intrathecal pumps cost about $8,000 less annually when compared to other treatment methods. Our group focused specifically on baclofen pumps for treating muscle spasticity in cerebral palsy patients. Baclofen is a gamma-aminobutyric acid agonist and inhibits the release of excitatory neurons that give rise to spasticity. As a whole, this drug acts as a muscle relaxant and an antispastic and can be taken in tablet form orally or injected. Please be warned that our next slide will contain a graphic surgical image. About 33% of the complications that arise from intrathecal baclofen treatments come from catheter failure, caused by the degradation, erosion, kinking, and motility in the catheter. Fatigue caused by wear typically occurs due to the high range of motion in the iliac crest. Poor pump catheter connections also present another issue. Leakage of this medication can lead to withdrawal symptoms, accidental overdoses, and unexpected medication loss. Bearing this information in mind, there are several ways to improve upon the catheter used in intrathecal baclofen pumps to help save lives.
So keeping these problems in mind, we came up with some design criteria to guide our design process. Our design with these listed components, which include a titanium catheter tip, a PET outer layer, a coating for the catheter, a silicone elastomer inner layer, and a V-wing anchor to hold it in place at the base of the spine, and sutures to hold that in place, came together to create a device that was required to be flexible, fatigue resistant, must encourage ECM growth and fibroblast migration, must not interact with baclofen or degrade with exposure to the environmental fluids, and must be image ready, especially with regards to the catheter tip. Our design objectives were that the device, especially the catheter, must be bioinductive, and the remainder of the device, which we did not redesign, must be biointegrated. The device as a whole, as we said, must be degradation and corrosion resistant. The overall cost of the device had to be around or less than 110% of the cost of the leading competitor, which we will discuss in the future. And as a whole, the device must promote ECM growth for stability. To achieve these goals, we had some numbers that the device must meet. The device must allow for infusion rates of 27 micrograms to 800 micrograms per day of baclofen, which is a range of dosages for baclofen treatments. And we said that by the end of the recovery time for the procedure to implant the pump, which is about 6 to 8 weeks, the ECM growth around the catheter must allow for about 75% of the stable state, which is allowing it to support the catheter.
Okay, so here's our solution to this problem. So the overall device again contains both the catheter, pump, and baclofen. We will be focusing in on the catheter. So the catheter would be implanted into the intrathecal space in the peritoneum. It would be placed around the transition between the lumbar and thoracic vertebrae, where length would vary, specifically depending on height. And it would also contain coatings for the bioinductivity in the intrathecal space in the peritoneum. So here's a diagram of our catheter design, including the CSF or cerebral spinal fluid and peritoneum catheter sections. Now there would be an outer polyurethane tetraphthalate layer and an inner silicone layer. Now the CSF coating would contain hydrophilic proteins and LOX enzymes, and the peritoneal coating would contain MMPs, ELPs, and LOX enzymes. Specifically, the reason why we chose these two types, the silicone elastomer and the polyethylene tetraphthalate, is because the silicone itself is inert and hydrophobic, and it's compatible with the drug baclofen, and the PET is biocompatible and thermoplastic. It would be able to withstand any bending or movement from the patient itself. So the cerebral spinal fluid coating would contain lysyl oxidase and hydroxylase enzymes, which would facilitate an ECM remodeling in the cerebral spinal fluid, as well as hydrophilic proteins for collagen 1 attachment. This is all so that we can essentially build a scaffold around the catheter in the CSF. This is our same goal for the abdominal coating, but it includes lysyl oxidase, hydroxylase enzymes, as well as MMPs or metalloproteinases, which additionally will help facilitate that ECM remodeling in the abdomen. And elastin-like peptides, or ELPs, would facilitate in binding to other elastin molecules and help with ECM tissue scaffolding.
These coatings in the abdomen would be delivered via a composite microgel, which would include hyaluronic acid cross-linked with tyramine groups, which is suited for protein loading and release over a 2-week period, which would coincide with the wound healing process beginning, and which is well suited as hyaluronic acid is already present in the ECM of the loose connective tissue of the reticulum, or the reticular loose connective tissue. Poly and isopropyl acrylamide cross-linked with polyethylene glycol and diacrylate would compose the remainder of the microgel. And this in particular is important because it decreases the chronic inflammatory response and leads to a 22% decrease in fibrotic capsule thickness.
So the coating of the catheter, specifically for the cerebral spinal fluid, the process would be solution mixing, where the coating would be mixed with LOX enzymes and various hydrophilic proteins in a PBS solution. And the coating of the catheter itself would be different because it would allow, so coating the catheter itself would include plasma treatment in order to aid in coating attachment, and as well, in order to help this coating attach, the catheter itself would be immersed for anywhere from 24 to 72 hours.
A few minor changes would be made for the abdominal version of this coating procedure. After the solution mixing, the gel would be loaded, and the catheter would either be coated in the same way as before or via a spray. Either way, this coating would have to be let dry.
Since this catheter is meant to operate inside the human body for long periods of time, it must first be subjected to a large battery of extensive tests, both in vitro and in vivo. In vitro tests include a wide variety of mechanical tests and cytotoxicity experiments, and in vivo tests must be performed in small and large animal models to verify that the catheter will be harmless to humans. The four main evaluations of mechanical properties test for ultimate tensile strength, fatigue resistance, burst pressure, and kink resistance. Each of these tests would be carried out using a bare silicone catheter as a control. Tensile tests and tensile fatigue tests can be carried out using an Instron machine, which pulls the catheters to failure at varied rates. Since a common failure mode of the catheter involves cyclic wear across a bony surface, a new device can be used to simulate this style of wear for testing purposes. Since the catheter will also be used to release a burst of fluid medication at regular intervals, the expansion and contraction fatigue must also be measured. This test can be performed by repeatedly filling and emptying a catheter using a pump. The cell response tests in vitro are slightly more complicated than mechanical tests, since these tests must determine that the catheter design does not kill cells, irritate the tissue it's embedded in, cause cancer, and the catheter must also exhibit that the cell growth properties it has been designed to have. Since the main development in this catheter involves promoting cell growth around the catheter, forcing fibroblast growth and accelerating ECM integration is critical. The catheter must be able to show cell promotion in vitro. This can be done by culturing cells and then seeding those cells onto a plate modeled after the catheter surface. Another set of in vitro tests can provide more information about cell responses. The catheter must be exposed to tissue cultures in order to determine how the cells react. The cell health can be monitored visually with a microscope. Since the catheter will not be transporting blood, only static hemocompatibility tests are necessary.
Previous small animal tests for catheters involved the use of rabbits for testing purposes. In these experiments, rabbits will be injected with saline solutions containing surface materials of the catheter, including growth factors. The acute and chronic responses to these injections will be monitored. And if these tests do not produce adverse reactions, then small sections of the catheter along with the control catheter section will be inserted intramuscularly into rabbits to observe the cell response. If these tests do not induce morbidity, then larger animal tests will follow. These larger animal tests will involve the testing of the full catheter system. The catheter will be inserted into the spine of pigs, and the pumps will pump radiopaque fluid that can be detected easily with imaging. The cell growth around the catheter and ECM integration will be monitored with imaging and tags, and migration propensity can be measured by imaging a standard catheter as a control. These tests will last for a short period and an extended period, potentially going on for over a year. Once explanted, these catheters can be inspected for signs of degradation. Altogether, this design will ideally present with lower migration, better tissue integration, and less leakage than standard intrathecal catheters. In summary, by reducing the need to go in and conduct revisional surgeries, our device will save a patient money over time. Although our device costs more to implant and maintain upfront, it will be safer for the patient and reduce the chances of kinking and catheter failure. As you can see here, the current devices on the market cost about $10.46 per day over the span of 1 year. That same device needing early on revisional surgeries costs about $44.59. Accounting for the materials used to coat our catheter, we estimate that our device will cost about $12.88 per day over the span of 1 year. With that, we would like to thank you for listening.